At this ESMO Congress, several studies conducted by the Urology Department team at Fudan University Shanghai Cancer Center were submitted for mini-oral presentation or poster sessions, showcasing our substantial research achievements to the global audience. In the field of advanced urothelial carcinoma, during the mini-oral presentation session, we reported on a phase 2 study of a novel bispecific antibody drug conjugate targeting 2 epitopes for the treatment of advanced urothelial carcinoma. The positive results garnered significant interest from experts. BL-B01D1 is a first-in-class EGFR and HER3 bispecific ADC, which is conjugated to a novel topoisomerase I inhibitor, ED04, through a tetrapeptide-based cleavable linker. In this study, patients were administered BL-B01D1 at various doses. A total of 23 patients received BL-B01D1 at a dose of 2.2 milligrams per kilogram and were evaluable for efficacy, demonstrating an objective response rate of 43.5%, a disease control rate of 91.3%, and a median progression-free survival of 5.5 months. Notably, for patients who had previously received first-line chemotherapy, the ORR reached 90%. The most common treatment-related adverse events were anemia, leukopenia, thrombocytopenia, decreased appetite, vomiting, etc., which were manageable. This study showed that BL-B01D1 exhibited manageable safety and encouraging antitumor activity in patients with previously treated advanced urothelial carcinoma. Further evaluation of BL-B01D1 in this patient population is ongoing. Additionally, we reported on T3011, an oncolytic herpes simplex virus expressing interleukin-12 and anti-PD-1 antibodies, in a phase I study for the treatment of BCG-unresponsive non-muscle invasive bladder cancer, with results showing a complete response rate of 60%. This novel therapy holds promise as a new treatment option for high-risk patients with BCG-failed non-muscle invasive bladder cancer in the field of prostate cancer. We further reported safety data from the phase 3 CHART study. Among the 654 patients enrolled, 323 were in the relugolix group and 319 were in the bicalutamide group. In patients receiving concomitant antithrombotic agents, drugs for acid-related disorders, or lipid-modifying agents, the incidence of toxicity in the relugolix group was comparable or slightly higher than that in the bicalutamide group, which may be partially attributed to the longer exposure duration of relugolix treatment compared to bicalutamide. In summary, the concurrent use of antithrombotic agents, drugs for acid-related disorders, and lipid-modifying agents during relugolix treatment had no or minimal impact on the safety of patients with high tumor burden and metastatic hormone-sensitive prostate cancer, supporting their clinical use in this setting. Furthermore, we reported on the single-arm phase 2 FAST-PC study, which used fluzaparib combined with abiraterone as a neoadjuvant therapy for localized high-risk prostate cancer, showing a PCR or MRD rate of 45.7% and a grade 3 adverse event rate of 17.1. Lastly, we reported a post-hoc analysis of the Spartan and Aramis studies. Recent recommendations from the EAU guidelines and the American Prostate Cancer Conference indicate that testosterone levels should be maintained below 20 eng or DL after androgen deprivation therapy. However, the current NCCN and UA guidelines still recommend a threshold of 50 eng or DL. Our post-hoc analysis of these 2 studies showed that lower maintained serum testosterone levels were not associated with disease progression after first-line treatment for non-metastatic castration-resistant prostate cancer,